Inequalities in healthcare. Obviously, it's so interesting. Someone's fallen over in excitement. So to answer those questions, we have a fantastic panel. And can I just please ask you to take care when you're walking up the stairs? No more people falling over. Let me introduce them to you now, and they will be taking questions towards the end of the session as well. So first, I am delighted to introduce Dipti Itchapuria, past president of the American College of Cardiology. Sri Vasi Reddy, co-founder and CEO of RAIN Foundation, which provides healthcare solutions through the Health Guru patient support platform. Charles Komoto, CEO and founder, Daktari Africa, a web-based telehealth platform that gives patients video access to doctors and specialists. Alexander Busser, head of product at Exploris Health, which develops artificial intelligence-based diagnostics and therapy solutions. And Ricardo Baptista Leita, CEO of Health AI, the global agency for responsible AI in health. Thanks very much indeed for joining me on this panel. So let's talk about where AI gets us and technology. And Dipti, let me start with you. Leading cardiologist, I know you've seen a lot of changes in the field of the healthcare. How do you see the current deployment of AI in both high-income and particularly low and middle-income countries?
Yeah, no, that's a great question. And there are differences, right? So the high-income countries have more advanced infrastructure, more resources. They also have more robust data availability, extensive high-quality data for AI training models, which is very, very important. They also probably have easier integration because they have electronic health records, so to deploy some of these tools will be easier. Now, that can be a pro or a con because low middle-income countries may have limited infrastructure, limited medical equipment, resources, a lack of comprehensive healthcare data. But at the same time, you can do more purpose-built systems. You can what we're seeing right now is the deployment of telemedicine with AI tools that are much more robust. And they really go to the areas which are needed in a lot of these areas. But of course, you have to think about the fact that they can develop models that we can use in higher income countries and do it more what we call frugal innovation, right? And the reciprocal learning that we can have between the low and middle income countries and high income countries is very much that. So for the first time, there's a real opportunity for global collaboration here. I also think that we have to remember that what we develop in high-income countries may not necessarily fit in low and middle-income countries, particularly with AI. They're different data sets. Let's not make the same mistakes that we made when we did randomized clinical trials, which is that we used a population of, white males, and then said it applies to everybody, whether a male or female. This is an opportunity for us to, like I said, do purpose-built systems and so I think there are lessons that we can learn with this. So deployment may be a little bit different. I do think AI tools could be used, what I said, for access issues in low and middle income countries. I think educational platforms are very prime for using AI tools in a lot of these other countries. So I think there are some differences, but I think there's a lot of opportunities.
I think the point about making sure the tech is relevant to the environment that it's deployed in is really important. I wanted to ask you, though, as a doctor as well, a lot of cardiovascular patients, particularly the older ones, they value the reassurance of seeing their doctors, right? They like discussing their prognosis with a human person. How does AI change that patient-provider relationship?
Another very, very important question. But I think the issue here is how to balance technology with the human touch, right? I mean, the three words that I would use is trust, empathy, and communication. I think that there is no replacing empathy with any machine, right? And so we're not replacing humans, we're augmenting our intelligence with this. So you could say AI, don't call it artificial intelligence, this augmented intelligence. So if we can augment what we can do maybe if we can take, routine tasks and automate them with AI, that would leave us more time for patient interaction, for example. I think that the idea of having time with the patients, listening to them, is helpful. But also, when we create these AI tools, we want to make sure we do patient-centric designs by taking into account who the audience is, who the patients are, and really think that whatever we're doing should enhance the patient experience.
Yeah.
And that will help build trust. I also think we need to be honest about when we use AI tools, make them understand that there are limitations to what we can do right now. I think that we need to ensure about privacy, trust, because there's going to be a lot of sensitive patient data out there. So we want to make sure that that's the data security there. And then communicate and have transparency about algorithms and all of that. But I think the idea that you can use this as a way to have more individualized data that may be tailored to you, who you are, rather than somebody else, I think it's very appealing to patients.
Pretty exciting,
right.
Yeah.
So I think if we just keep those three things in, empathy, trust, and communication, think about patient-centric models, I think we're going to be in a good place with this.
Empathy, trust, communication. So that brings me to you, Sri. Tell me about Health Guru, because this is a tool which allows patients to access doctors and medical care, even in remote areas.
Right. So actually, when I started the foundation, and fortunately, I was looking at what real difference can we make, and what I realized is there is a lot of effort that is going into access, and there's a lot of money in access. But when it comes to adherence, which we have been talking about a whole lot today, right? There are not a whole lot of solutions in adherence, and there is not a lot of money to make in adherence except for like HIV or TB programs. But in non-communicable diseases, how can we improve adherence? So I set myself a goal to say the ultimate adherence will only happen if it happens automatically with zero effort for the patient, which is an unachievable goal. How close to unachievable can we get? So good example, like say if you're a heart failure patient and you have to take your weight every day. If they sit on their commode or get off their commode, the weight should be taken, weight trend should be maintained, and they should send a signal if there's a weight increase. So that is an example. And so what we have decided to do is create a platform, Health Guru, which helps with self-management, in vital management, medication management, symptoms management, nutrition, physical health, and mental health. And it is free and open source. So the service is free, the intellectual property is free, and it has already been applied, like American Heart Association uses in the US, and like Professor Odili we are co-creating for hypertension, working with Professor Imam to do heart failure. So the idea is people shouldn't have to do the undifferentiated tech-heavy lifting. We should just focus on science, because the real difference is getting the content as specific to the user as possible so we can make the real difference.
What about Dipti's point about considerations over data privacy and information security?
So I think from a data privacy perspective, there is not a whole lot of difference from the challenges we had in just regular digital health. I mean, PHI information management, all that, we should still maintain. I think HIPAA standards or whatever the equivalent of HIPAA standards still hold. The real problem is the safety side of things. So what I mean by safety is it's very easy for anybody to build an app based on LLM. You can pose a question, get an answer. But the real work goes around drawing the boundaries. So don't ever give a diagnosis. Don't ever prescribe medication, right? It is about focusing on all that safety and also making sure that you have the right context before you give the advice. And that means that bulk of the work is accessing that content, creating the right context, creating the right question, and bringing about the right safety. Right, so.
Sri, thank you. Charles, let's talk about Kenya, high blood pressure, a particular problem in Kenya. How does Daktari Africa use AI to enhance hypertension management, and how popular has it been?
Yes, thank you very much, Dipti, and to the organizers for inviting me here. There was a magic number 3 at the beginning of this day, and I think that applies in this case. So thank you so much. And I'm a fan of Man City, so you can extrapolate from there.
Oh, we're so sorry.
But yes, so I really believe that artificial intelligence is poised to be one of the greatest tools in medicine, and I'm really waiting to see how it will end up being deployed, because really it will be a game changer in so many ways. Hypertension, as you all know, is the most important cardiovascular risk factor, not just in Kenya, but around the world. And AI really has many ways by which it could actually contribute, and I'll tell you about how we apply it in Daktari Africa as well. So first of all, artificial intelligence algorithms are able to actually analyze large amounts of personal and public or population data, medical data. And they're able even to compare that and to integrate it together with data from scans, either imaging scans, retinal scans, which are able to detect early signs of high blood pressure complications, genetic information. So there's so much really that AI can gather and integrate and be able to predict the likelihood of developing either hypertension or its complications. So these are one of the ways by which predictive analysis, which is one of the areas of AI, can be used. And also, of course, something related to what Shri just mentioned, which is the whole aspect of, number one, coming up with personalized treatment plans, depending on all those records. And so doctors will be able to actually prescribe the appropriate medication, given all that data that we have. And also to recommend lifestyle changes, because we know very well that it's not just about medicines, it's about nutrition, as we heard earlier, and it's about the lifestyle changes that we adopt. And of course now the aspect of medical adherence to medication. How do those patients actually take those medicines? Because we'll be very busy prescribing meds whenever the patients come, but do the patients actually buy those medicines? Do they take them as they're supposed to? Then of course there's the aspect of wearables. That's a huge one, whereby we'll be able to have real-time psychological data and physiological data even, right? Psychological, because some of these gadgets which have been thought of are actually able even to measure the levels of certain hormones in your body. So there we go. That's another area which we can delve into when it comes to ethics. So basically, artificial intelligence will be able to do all that. At Daktari Africa, what we've been doing is we've been combining telemedicine, which we've been doing now for 16 years, with ECGs, for example, AI-enabled ECGs. So for over a year now, we've been looking at a particular community that has HIV, and we've been attending to those patients who also have NCD, so they don't have to travel to look for a physician in a different hospital. So we see them right from there and using telehealth. And recently, we partnered with GE Healthcare, and we use their AI-enabled Muse cloud system to be able to actually interpret those ECGs. So what we're doing with that, Dipti, is that we are actually making sure that we don't have algorithm bias, because sometimes those ECGs, as Dipti was saying, sometimes the ECGs can lead to a certain diagnosis. We know that very well. But sometimes you need the human experienced clinical eye to say, well, this is not a normal ECG, this is actually atrial fibrillation, et cetera, et cetera.
Can I just ask, because one of the things that was mentioned in a previous panel was that all this tech is really exciting and really innovative and could make a difference, but it's pointless if people can't access it, if people can't get hold of it. So how do we ensure that everyone gets hold of this technology?
Yes, thank you very much. So what we're doing, as you know, ECGs, for example, that simple, basic, so elemental and important cardiac diagnostic test. Really, can you imagine that only about 21% from a survey that was done by one of our colleagues, only 21% of hospitals in Kenya right now have access to an ECG. So it actually comes to that, you know. And the point is that this is a test that really will make such a big difference in early diagnosis and in management of these conditions. So what we're doing with at Daktari Africa and with partners such as GE Healthcare, and we're open to other partners as well, is to make that simple, important diagnostic test to be available to everybody in the country and beyond. So we're essentially democratizing ECG diagnostic, cardiac diagnostic test. And then we're using AI to be able to make quick interpretations. But again, we're having now our doctors, we have about 600 plus doctors on our panel, and we're working with some of them who will then have access to that platform and be able to carry out a validation of that interpretation. So that's part of the role that we're playing with.
Thank you very much indeed, Charles. Alex, let me come to you. I want to talk a little bit about how this kind of technology can make things easier for health professionals as well as for patients. And Exploris recently won a major award for the Cardio Explorer. This is a test for coronary artery disease, which is far more efficient than tests we've seen before. Tell me about that and how it helps diagnosis become easier.
Sure. First of all, thank you so much for having me. I've been spending 12 years doing research in AI in diabetes and sleep sciences, and only 2 months in cardiology. So it's an honor to be here and to learn from you all. And it's great that we have the opportunity to share our story. So as you rightly said, the Cardio Explorer essentially is a software with an AI algorithm that allows physicians to enter different blood markers, demographic factors and treatments to then reliably detect a risk of coronary artery disease. We've developed a solution using AI, and AI was used in 2 critical components. One, it allowed us to detect relevant markers from 1,000 different tests, as well as effectively describe the relationship of those markers to the presence or absence of a coronary artery disease. Another very central aspect where we're using AI is in the validation of those tools. So many of the data sets that we get access to and actually evaluate and train our systems are often from high-risk populations. And as you can imagine, performing an angiography on a low-risk population wouldn't be ethical. So we are using AI to create virtual patients whose characteristic mimic those of low-risk patients to test our system and to calibrate them to broaden the access of the system. Our tool is clinically validated. It is CE marked. There's 15 years of research that went into this tool. And it's now being successfully used by clinicians here in Switzerland. It's covered by the complementary insurance, and we're working with a large steel manufacturer in Germany who is routinely screening their employees for the risk of coronary artery disease. What is also very promising, we're like a large insurance company in Germany came to us. They're currently conducting a prospective study to substantiate their claim that our tool would be able to save up to 300 million euros in Germany alone by avoiding unnecessary angiographies.
Wow.
But we're still working on further access.
So small success then. Well, congratulations. It sounds like a great tool. Presumably as a manufacturer, all these concerns about safety and data privacy are what you consider when you are building this tool.
Yes. Yeah, that's a very central point, and a lot of our resources actually go into ensuring that our systems remain safe. It's actually another use case where we use AI to kind of penetrate our system to expose security vulnerabilities.
So you use AI to check how safe
yes,
AI is. Love
exactly, yeah. And we also employ what we call white-collar hackers. So we employ people to actually try and hack our system, which gives us another insights on how to make our systems more secure. And the good thing is all of these softwares are highly regulated. So the regulator actually imposes standards on how to build secure software that keep patients' data safe.
Alex, thank you very much indeed. Ricardo, so we've heard a lot there about how AI innovations can greatly improve cardiovascular healthcare. In your opinion, just how transformative is AI? Could it fundamentally change entire health systems?
Well, thank you for the interesting question, and good afternoon, everyone. Good afternoon. Thank you. I know it's mid-afternoon, but I love seeing people in suits doing strange exercises in the middle of a room like we did before. So I know you guys are active bunch, and so I'm really happy to be here. And yes, we are in the face of the most transformative technology since penicillin in healthcare. And the way it is going to transform in many ways, no one knows in reality. And it's very important to be humble when dealing with artificial intelligence because, you know, when we're looking, for example, in the European Union, how the EU Act on AI that wants to regulate artificial intelligence was putting, it's a risk-based model looking at what is most risky, what is less. And large language models, in the beginning of that process, were considered low risk until ChatGPT was launched. And so can I see a show of hand? Who has used ChatGPT at least once in their life? Okay, good. So you guys know what I'm talking about. And so ChatGPT came out, and the legislator said, oh, maybe this is high risk. And so it shifted to high risk. But what I'm trying, you know, in a very simplistic way, trying to say is that we don't know what's next. And so what we need is not very strict legislation. What we need is light legislation that empowers regulators so we can have effective regulators. And if we do that, then we can address, I think, one of the fundamental issues when it comes to this transformative technology. And when I say transformative, is really transforming the health system as a whole. So the big challenge here, and I'll get to the transformation part in a second, the big challenge here is really, on one hand, there's fear. We did actually a survey at Health AI to a whole bunch of stakeholders. Fear was the most common word we heard. And it's fear because of the potential harm the technology can cause, very much hyped by the media, but also fear due to lack of understanding of the technology or how to deal with it. But on the other hand, that fear factor leads to lack of trust. And without trust, people do not use the technology, and health systems will not embrace the technology. That has the potential to actually lead to better health outcomes. So it's a double risk game that we need to, that's why we need to fix the governance of AI. And what I see as the biggest transformative opportunity is not just the tools. You know, Alexander shared here a great example on digital twins here, basically used in the healthcare space. But even further than that, thinking about the fact that we have a broken health system around the world that is focused on disease, and that is only leading to more cost and to a greater burden of disease. Artificial intelligence represents the opportunity we've been waiting for to use big data to be able to rethink the model altogether. That's not what is happening today. What we're seeing is this broken disease-driven model is being exported now to low and middle income countries. Right. You know, I was a member of parliament for many years in Portugal, and I run a network of parliamentarians in health, and I see how many times politicians prefer to open a new hospital than invest in digital because a hospital shows up on the front page of a newspaper. But actually the digital transformation, maybe you don't need so many hospitals. You can actually rethink the way we use the technology. And I think the opportunity here, and being here at the World Heart Summit, being with the burden of disease that heart disease represents and cardiovascular disease represents, we should actually look at this technology and say, okay, if we didn't have this old health model in place, instead of retrofitting the technology into our current model, how would we design it for the future? And if we do that, we can actually lower the burden of disease, make sure that people are focusing on making sure that citizens have healthier, longer lives, but also focusing on their well-being and quality of life. And that, I think, is the greatest opportunity at hand.
See, I think that is a great solution. And I think one of the things about AI is it's quite divisive, as you've said. I want to ask two questions. Question number one, who is excited about what AI can do for the future of healthcare? Okay, and question number two, who is and/or worried about what AI means for the future? Yeah, so it's a double-edged sword, right? So how can governance help overcome that trepidation, if you like?
So that's where I'm very proud to leading a team at Health AI, which is the Global Agency for Responsible AI in Health. We're a nonprofit foundation based here in Geneva, working in partnership with the World Health Organization and several other multilateral organizations and governments as an implementing partner. And our goal is really to make sure that the world is able to achieve what I would call a minimum bar of regulation when it comes to artificial intelligence in the field of health. You know, back in the 1950s, there was a drug called thalidomide that was put into the market, and in the markets where there was no regulation, it was used as an anti-vomiting drug given to pregnant women. More than 10,000 babies were born with birth defects. Many more died. The silver lining of that global tragedy was a new era of regulation. Today, 70 years later, nobody questions what is a double-blinded randomized clinical trial, what is authorization to access to market for pharmaceutical products or medical devices. Nobody questions health technology assessment. If we could build a similar ecosystem in which countries, including low and middle income countries, have the minimum capacity to address many of the challenges that was mentioned here in terms of data set bias, of local context, but also transparency, accountability, fairness of the technology, we actually have a unique opportunity to learn from lessons past while we are still early in the game, ahead of the curve, and make that a reality. Because as was said here, there are countries that are doing already fascinating work when it comes to ensuring safe technology is put into the market, but it's already the richest countries in the world that are doing that. Once again, AI, which can be the greatest equalizer, also has the potential of being the greatest divider of our time.
Yeah.
It is addressing that challenge that is our unique opportunity here, and I invite you all to join the Health AI community of practice through your institutions, because it's really necessary to bring private sector, governments, academia, patient organizations. We need everybody from a bottom-up approach to avoid the mistakes of the past so that we can build that future that I was talking about.
Thank you, Ricardo. Dipti, you were nodding along enthusiastically. Yes, it does deserve a round of applause. One of the things Ricardo was saying that people often would rather build a hospital than invest in digital transformation. We know that AI is key to driving research and innovation, helps us decide where to resource, allocate, and where the areas of the greatest need are. What is your view on the usefulness of AI in that department?
Yeah, so before I answer that, let me just say I completely agree with Ricardo. I think this is a real opportunity for clinicians, developers of this technology to work hand in hand. And I believe this is a time where you can't have people coming out with solutions and then saying, what is the problem we're tackling? We need to identify the problems and then come up with the solutions, which is something that's almost unheard of, but it's this co-creation with clinicians right there, hand in hand with engineers to come up with the idea. And then also being really aware of the potential problems as he outlined. I think that's really where we're gonna start seeing the change that we need. If you think about cardiology in just general, I'm digressing a little bit. Cardiology is a very tech-savvy field. We've adopted technology, but if you think about our waiting rooms, they look fundamentally the same in 70, 80 years. So I think we haven't transformed the way we deliver care, and that's what this is all about, is how do we deliver care in a more efficient way and democratize it so that we don't have, these issues. But I think with your question about research and innovation, I think the big strength of AI is the fact that it does do pattern recognition, that we can get data-driven insights. So it can look at large, vast sets of data, whether it's from remote patient monitoring, electronic health records, other sources, but then maybe come up with some insights so that it becomes hypotheses generation, right? To say, hey, this may be an issue. Maybe seeing things that we're not able to see by looking at large data sets. So that's one thing. So I think that can help us do hypotheses generation, number one. Number two, we talked earlier about the issue of trying to get a diverse patient population. And I think it's going to be easier to identify patients that would be eligible for trials based on using AI diagnostics on those. Also using AI tools to ensure that people are adherent to the trial design. So I think all of that. I also think that may be a way to do global collaboration with our data. When we do research, we may have a platform that we can use to exchange data. And then also real-time data that we can get during the trials can maybe course correct things as we go along. So I think...
So you end up with something that's precise
Right.
much earlier in the
Right.
process.
Right, and not wait till it's end of it to do course correction, because what everybody's asking from now on is where point of care. I want things at point of care, real time. And with all the technology, why can't we do things more real time?
Sure. Okay. Thank you very much indeed, Dipti. Charles, have you seen any concerns from patients? Do they trust AI in the healthcare system?
Yeah, that's a good question. Actually, I think they trust it a little too much. We already saw that with Google. So many people actually go to what, in Kenya we colloquially call Dr. Google. Why is this? It's simply because many people at home, back in Kenya and I know around the world, will actually query their issues and they'll see what Google has to say. And I like what Ricardo has said, that we need to be careful about some of these AI models not prescribing and not giving a diagnosis. We know, unfortunately, that that's exactly what happens. They actually give all that information. So very many patients, and I'm not saying that it's a bad thing to go to Google, as long as you end up going to your doctor, you'll be better informed even as you go to see your doctor. But very often they actually don't, and there's this whole aspect of self-prescription. And that's one of my concerns now with artificial intelligence, because with ChatGPT 4.0, you can actually even converse with it. You can talk to it, and it'll talk back to you. So it's amazing what many of these, large language models have actually managed to do. It's just awesome. But again, my concern is, yes, many patients are going to trust it and trust it too much. Are doctors going to trust it? We've already heard that they don't. Very, very often we query what goes on in that black box of that algorithm decision-making model. What really goes in there? How does it come up with those decisions? So you'll find that many doctors actually don't trust it, don't trust artificial intelligence that much, you see? So
Right.
it's interesting, the view that many people have. I still think that we can actually use it and use it effectively, but there's that element of trust which came up a little earlier. And again, we've heard about trust, we've heard about empathy, we've heard about conversations. And I'd like to talk a little bit about this aspect of conversations, because you can talk to various things. You can talk to plants. There are people who talk to their plants as they're watering them and stuff, right? Dusting them. You can talk to your pet, right? And pets are actually very therapeutic, they say, right? You can talk to an adult, or you can talk to a doctor. But can you talk to a machine? Because that's what AI is. And very often, the quick answer for us will be no.
I think it depends how you program the machine.
But then you ask yourself, what about Gen Z?
Yeah.
Who have grown up with AI from when they were little kids. And that's, when they're in distress, that's the first place they go to. So you'll find there'll be a generation that trusts it even more. And that's a danger.
And I think that is going to change in the future. Alex, let's talk about the challenges of getting more tech out there that can make a difference. What are the challenges you face as an AI diagnostics manufacturer in trying to get products to market?
Yeah, so as a tech person, I of course don't see the problems in the technology. It's always vice versa, right? But actually, in our case, it's predominantly providing access to our technology. So the reality is, having a proven clinical benefit and having market authorization is not enough for such solutions to be adopted. Often, particularly in Europe, it's necessary for a solution to be reimbursable, as well as ideally having a mentioning in guidelines. And that process of getting reimbursement as well as being included in guidelines is a very ambiguous process for a small organization. There are some proven ways. Pfizer, for instance, very famously conducted hundreds of trials to get statins mentioned in the guidelines. But as you can see here in this round, it's predominantly small organizations that are driving the innovation within the AI space, and we simply don't have the resources to do that. So that's definitely one of the risks. The other thing I'm seeing or we're concerned about is that guideline adaptation doesn't match the speed of technical innovation. So there's a real risk that these innovations don't get timely recognition. For instance, in the German-speaking area, in the guidelines, still like pre-probability or risk scores are recommended, despite there being a lot of clinical evidence that those tools don't effectively triage patients, right? So we are really grateful for any suggestions, ideas on how some of these challenges can be overcome so we can provide more timely access to better and innovative solutions.
Well, Ricardo, this is kind of your field. Do you think small companies are impeded by the guidelines and the processes that they have to go through?
I think it's a very competitive market, no doubt. Just in healthcare, we foresee that the AI in healthcare market will be valued in 2032 at nearly $500 billion US. And so this is going to, of course, be transformative. A lot of the big players are out there. We know who they are. And it's quite interesting to see how, so here in the European region, if you look at the hospitals and clinics, everybody's so worried about data privacy and data ownership. 99.9% of hospitals in the European region have all of their patient data on one of 3 US-based cloud systems. And so it's either Microsoft, Google, or Amazon. And that's a discussion we have to have very openly. And so that we can overcome many of the mental barriers that we have so that we can responsibly use the technology and accelerate those that are actually building innovation in the region to go faster and even beyond. If we think about low and middle income countries, the challenge is even greater. And then there are other challenges. So one is showcasing the technology at a global level. So that's something at Health AI we're hoping to be able to achieve. So with WHO, we're aiming to build a global repository of AI solutions. So as soon as a technology is approved in one country, it'll be showcased on this global marketplace for the world. And so everybody can see that a tool that has been validated as applying responsible AI principles is showcased there. And so this is great for a startup in Kenya. In Nairobi, the first place they're going to get validated is in Kenya. But
Right.
all of a sudden, we have that technology for the world. And we saw how, with M-Pesa, for example, in the financial sector, innovation coming from a low and middle income country was capable of being transformative for the rest of the world. The problem is many times we don't have a mechanism through which we showcase technologies coming from smaller enterprises or from different regions of the world that are actually coming up with amazing innovation. The other challenge I would like to highlight, we haven't mentioned, and it's not spoken about much yet, but it's going to be a major problem at the speed because we're at an exponential curve, which is the climate issue. We are using today already, AI is already consuming 1 to 3% of the world energy. Some people are saying it could be near to 10% of the world energy. AI, the big AI companies are already investing heavily in thermonuclear energy plants to fuel the AI development. How can a startup compete with this is something that is a big issue. Second is on water. So, you see, I talk about big tech, they always hit on me.
Let us just check it's not an actual fire. We'll carry on for the moment.
Yeah.
If we need to evacuate, I'm sure we'll do so in an orderly fashion. Just very quickly, because we are coming to the end of the time, and I want to get
So the second issue is water. 1.7 billion gallons of water are used every year right now to cool down the AI system. So that gives more or less half a liter of water for every question we put, for every prompt we put in ChatGPT. So if you think about that, we understand the tremendous climate impact that the technology can have and how we need to embed this from a governance perspective.
Thank you, Ricardo. I'm going to take questions after this next answer, so please do feel free to line up very quickly, Sue, because I do want to get some questions in from the audience. Your view on how AI can help with better adherence in cardiovascular care among patients?
Yeah, I think some really good examples, like for example, the previous panel was talking about antenatal care. So one of the good ways is we have a solution where if somebody posts their conjunctiva on WhatsApp, we'll screen them for anemia. Right? It's a screening test. It's not a diagnostic test, but it gets a lot of people to be able to do that. Right? Another similar thing, we talked a lot about nutrition in the last panel. If you just say what you eat every day, then we can understand that and derive the calories and what kind of calories you're getting from, understand how much salt you're consuming and things like that. So these are very democratized solutions that we can offer. And the third example I'll give is, like today, people use ChatGPT or any AI solution to be able to say, if you're planning a trip to Geneva, a 4-day trip, give me something, right? Similarly, you can also say, these are the ingredients that I have, or this is what my doctor told me to do. Give me a plan to, to adhere to that, right? So we can create these kinds of things that are very accessible, which we are actively doing, and then really democratize that to the rest of the world.
Personalized to an individual
Exactly,
patient. That sounds great. Thank
Yeah.
you. Thank you very much indeed, Sri. Yes, gentleman at the front of the queue.
Hi, thanks very much. My name is David Lloyd. I'm from the Heart Foundation in Australia. Ever since I first used ChatGPT to write a submission to the Australian Pharmaceutical Benefit Scheme for me in 7 seconds, I've been a great fan, I have to say. Beat my chief medical advisor by about 5 days. The issue I have, though, since then, I've had a lot of conversations where we, I think quite unintelligently, say, yeah, AI will probably fix that. We don't really know what we mean by that, but it's sort of a comforting way of kicking the can down the road. One area that's come up a lot is the issue of guidelines. So we're now gradually reaching the view in Australia that our clunky process of developing guidelines can't keep pace with the development of new knowledge. So the moment we table these new things, they'll be out of date. As a result, we're not producing guidelines much anymore, which means that we're getting even more out of date. And the sort of lay description that we have of the solution is that one day there will be an AI that will be able to shop in the best that's thought and known in the European guidelines and the American guidelines. It'll magically adapt them for the Australian context, and then in real time, every GP in Australia will have what they need to know on their phone. Is that realistic? And if it is, when's it going to happen, please?
By all means, Sri.
I mean, at least start off, but I think, this AI, end of the day, is a tool, right? Just to think that AI will magically fix something is incorrect. I mean, if I look at a painting, right, a brush or a palette and color magically did not do that, right? It's, it took the creativity of a person with whatever guidelines they had to do it. That's the evolution for any problem, is going to be how we humans come up with it and get something done out of it.
But this question about AI is evolving so quickly. Can we keep up? I mean, you were alluding to this, Ricardo, I think. And Charles, do you want to say something on that?
Yeah, I just want to agree with Sri on one point, which is that it'll take natural human intelligence to guide the artificial intelligence so that we employ it the way we should. And one of those ways is by using AI in real clinical settings, whereby as many people as possible actually are using AI, and where the different platforms are talking to each other, so that results of real clinical situations are integrated into those guidelines. What do I mean? I mean that, in Clinic X, Clinic Y, Clinic Z, this patient is receiving this antihypertensive. This other patient in Clinic Y is getting this other hypertensive, and he's a totally different person. And Clinic Z, something similar. And the results will be seen from the actual control of the blood pressure to the side effects, et cetera, et cetera. The Creole study, and we have two authors here. We have Prof. Ogola and Dr. Mpiko, who actually were involved in the Creole study, which actually helped to show which were the most effective drugs to control high blood pressure in Africa. Because very often, and there's an article in the latest New England Journal of Medicine that's dedicated to artificial intelligence called NEJM AI. There's a wonderful article called the Great Medical Data Divide, meaning that sometimes pharmaceutical companies come up with recommendations which are based on research where they've missed out on whole continents, even Oceania, Africa, and yet those drugs are meant to be used, according to them, all over the world. But it's just not practical. So what I see it's possible. Once enough people are using AI, the guidelines will just be updated automatically. So what's the latest guideline on this? And you'll see it change in real time. It's just like the stocks, the way the stocks change. That's how I see it happening.
Okay. Very quick intervention from Ricardo.
Yeah, I just want to say I disagree with everything. Because I honestly feel that 10 to 20 years from now, we're not going to have guidelines anymore. It's going to be so precision. It's going to be focused on what is right for that patient. The question we have to ask ourselves is our country organizing the data and structuring and labeling the data in a way that we can maximize the potential of the technology for that individual precision personalized use? Most countries are far from that. And the date at which that is going to happen, nobody can foresee because of the exponential growth. I saw a BCG report saying 2030, but I think it's just because it's a round number. Nobody really knows.
Okay, so either automatically updated guidelines or no guidelines. A very comprehensive answer, thank you. Yes, lady at the front.
Yeah, so my name is Dr. Guria. So I'm a physician and a researcher, mostly in non-communicable diseases in Africa with some digital health interventions more recently. So my question is about equity and application of your intervention. So we actually had one of the Gates grants, I think Charles, you might have as well, last year, called Catalyzing Equitable AI in Kenya, and we were looking at 19 to 35-year-olds, and we found systematic differences in acceptability of implementation of this LLM-based app by gender, by education, and by rural versus urban context. So I'm curious to see your own experiences and how you've considered in your different interventions, programming and training with that in mind. And I'm also curious, as a suggestion for Health AI, thinking about legislation and policies being an intervention for equitable intervention, how you're thinking about incorporating that in some of your approaches. Yeah.
Well, let's take the first one first. I was going to come to Dipti, but does anyone else? Okay.
Yeah, I mean, I can. Just what Dipti said, I look at AI as augmented AI, at least in this stage, before it goes to full artificial intelligence. So if there is an equity problem, and if replace that AI thing with a human, if there is a gender issue or an age issue, how would we deal with it? You would have to do the same thing, to go back to the drawing board, and rebuild your model to incorporate whatever deficiencies it has, right? I mean, that's how I would go about it.
I do think that when you design the AI model, you have to make sure that you have those the diverse population, but also making sure that your training set and your testing set is different, so that you make sure that you don't have those biases, so you have more equitable, you have that diverse population.
Can I just put that to Alex then, because since you actually manufacture AI diagnostics, is this a consideration? Different socioeconomic groups, different genders, different regions?
Yes, so I mean, just also to put it into context, right? Often to get an algorithm that works reasonably well, as ChatGPT, it would take us maybe 3 months. The rest of the 5 to 6 years is actually spent on investigating the algorithm's performance on different demographic groups, different risk profiles, and then trying to fill the data gaps, right? I mean, I mentioned the example of trying to get data of high-risk population, right? AI systems today, at least the technologies that are available to us, they perform really, really poorly if you are unable to provide them with actual patient samples. And so tremendous efforts go into actually filling those gaps. So yeah, I hope that gave a bit of context.
Thank you.
Yeah, maybe I can just add something just to answer to Garia's question. I think that really it's all about the quality of data that gets into the AI systems to be able to come out with proper conclusions. We had the expression in the earlier session, you are what you eat. So similarly, good data in, correct conclusions out. And one of the ways in which we gather that data is by working very closely with community health workers on the ground. So even when you do our telehealth services, we have trained community health workers, and we do capacity building so that even those community health workers on the ground are well trained as to diagnosis of hypertension, gathering the data that the patients, the medicines, etc., that the patients are using. And we're fortunate actually to be working with Institute ECHO, based out of University of New Mexico. So we work with them to carry out capacity building. So the quality of data is really, really important. Sometimes I see AI, I like the analogy with penicillin, because really penicillin helped the Allied forces to win the First World War due to Alexander Fleming's discovery. But another analogy for me for AI is a Ferrari. We heard earlier on that I think one risk factor was poverty. So when we all own our Ferraris, make sure your wheels are in good shape. Because you can have a very powerful vehicle, but if you don't have the proper grip on the ground, you're off, right? So safety of these AI systems will depend on the quality of data. So
I'm liking your analogies there very much. Thank you. Listen, we've got time for one more very quick question. Go ahead, Selena.
Hi, Selena Gore, CEO of Women Heart. A number of you mentioned the role of the patient in the development of these models. I would love to hear what you consider to be effective and true engagement from patients. Because as you might know, many of the ways that patients are engaged are really superficial, they're not meaningful, and patients are left frustrated.
Okay. Importance of patient again.
A few of those
It's a great
examples.
question. It's a great question. Thank you. Yeah, input from patients. Alex?
There's probably room for improvement here. I fully agree, but I can just elaborate how we currently engage with patients. So that's one, of course, in the course of collecting data, right? This is through routine trials, and there, of course, we obtain patient consent. We adhere to the Helsinki Declaration, work with local ethics committees. So that's one aspect, right, in the data collection part. So patients are aware for what their data is being used. And the second aspect is once we actually have a well-working algorithm, right, we work very closely with patient groups to get their feedback on the usability of the algorithm, right? So this is all about user-centered design and understand how to use the product and how we can make it easier to use. So these are the two main aspects in the development process where we engage patients.
That's reassuring to hear. Thank you. I think that was a really, really wide-ranging conversation. We are really out. You see the flashing lights there? I'm afraid artificial intelligence has decreed that we have run out of time. We're all going to be slaves to it eventually. And this time next year, it'll be ChatGPT sitting here asking the questions. I know that. But thank you so much indeed for your insights. I think you've posed some really interesting questions, but also really exciting developments about what could be possible in the field of cardiovascular health. Please give my panel a big round of applause.